Good morning, everyone. Thank you for joining the American Head Neck webinar, AHNS webinar, presented by the AHNS Global Outreach Service. The topic for today is implementing standardized care and new technologies for head and neck cancer in the under-resourced areas. I'm Dr. Deepa Nair. I'm a head and neck surgeon from Tata Memorial Center, Mumbai, and I welcome you all. Our panelists for today are Professor Erivelto Volpi. He's from Brazil. He's a head and neck surgeon, and he's going to be talking on the implementation of minimally invasive techniques for thyroid nodules in under-resourced areas. We also have with us Professor Luiz Kowalski, who's an MD from Brazil. He's a very senior head and neck surgeon, and he would be talking about how we can develop survivorship and rehabilitation programs in the under-resourced areas. I myself will be talking on role of neoadjuvant therapy in advanced oral cancers. Professor Prathamesh Pai has some issues and may join us later in the session. We will see if he joins in. And over to you, Professor Volpi.
Well, good morning. Thank you for the invitation. It's a big honor to be here and share our experience in how to implement minimally invasive thyroid treatments in under-resourced areas. May I share my screen? My name is Erivelto Volpi. I'm a head and neck surgeon from Brazil. My talk is about how to implement minimally invasive techniques for thyroid nodules in under-resourced areas. It's a big honor to be here and share my thoughts with you all. I declare that I have no conflicts of interest in this presentation, and we know that surgery is the gold treatment in terms of treating thyroid cancers. And of course, still developing new techniques like endoscopic and robotic thyroidectomies is associated with increased costs. And of course, complications like hypoparathyroidism and laryngeal nerve damage can occur. We know that these tumors are associated with a very good prognosis, which supports less extensive surgeries, but even less extensive surgeries, hypothyroidism can develop. So why do we use minimally invasive treatments? Because there are a significant number of thyroidectomies for instance, in the United States annually. On the other hand, more and more patients are concerned about their quality of life, and now they have easy access to information and, of course, are looking for less aggressive treatments. We have new technologies that can safely, nowadays, treat thyroid nodules without removing the gland, and with very, very good results. So, when we are talking about thyroid cancer, thermal ablation, specifically radiofrequency ablation, could be another path between surveillance and surgery. As you can see here, we have a patient with micropapillary thyroid cancer. And the top, you can see here the electrode treating the nodule, and in the bottom, at the bottom, you can see the treated area. Not this treated area is bigger than the tumor, because when we treat malignancies, we have to reach an area beyond the nodule as a safety margin. Here we have another example, very young lady, 24 years old, with small thyroid cancer that refuses active surveillance. You see the tumor here. The treated area after 3 months of treatment note the size of the treated area is bigger than the tumor itself. So after 6 months, you can see the shrinking of the treated area, and after 11 months, you just see a scar where was the tumor. There is no more evidence of the tumor. So not only for small cancers, but for recurrence of neck metastasis, radio frequency and other thermal ablations could be a good alternative, especially for patients who are at risk or refuse surgery. Of course, strong knowledge of local anatomy and ultrasound anatomy is pivotal for the success of the treatment. And the diagnosis should be proven by final needle aspiration and thyroglobulin on the washout. And for these patients, it's mandatory to have a good experience in final needle aspiration and thyroid ablation. Here, a tumor metastasis on the level 3. This is a old lady, 73 years old, high risk patient. You can see the jugular vein, the carotid artery, and the metastasis. And you can see here the electrode inside the metastasis doing the ablation of the tumor. So, which are the barriers to implement these minimally invasive thyroid treatments for thyroid cancers? We have I bought 6 challenges. These related specifically to the doctors who the number one is the knowledge to know about and acquire understanding of the thermal ablations techniques, the training, how to get expertise in this technology, the medical education, so how to convince colleagues about the effectiveness and applicability of the technology, and others related to implementation, specifically implementation of these treatments, how to deal in limited resources, to deal with the lack of resources and infrastructures constraints, and also who will pay for, who is the paying sources, the government, the insurance companies, or the patient itself, and we need to prove the cost effectiveness of this procedure. So I will show my, show you my own experience and how I acquired knowledge on this and training, because I went to acquire knowledge on this technique. I went to SU. I made my training with Dr. Beck in SU, and after I reaching the peak of my learning curve, me and other colleagues from Brazil, we started to share our experience and training colleagues, not only from Brazil, but from all the Latin America and other countries. Now we have training more, almost 200 doctors, not only surgeons, but also radiologists and endocrinologists in perform to get the knowledge and the confidence to perform RFA. We are very proud to training all of these doctors. The second is medical education. You should show your results and show your experience and your expertise, and show to convince your colleagues that RFA is a good option to treat thyroid cancers when the indications is right. It's the most important is to know the indication, the correct indication to have the best results. Of course, we need to understand that when we have a new technology, we have the adoption curve, not only for specifically for RFA, not only for medical treatments, for any new technology. And you have at the beginning the early adopters that will embrace these new technologies and will help to share this technology. And step by step, more and more colleagues will believe in this technology and will accept this as a good option for specific patients. And of course, there is a part of our colleagues that will be more resistant to accept. Well, how to deal with limited resources? Of course, resources is important, is pivotal to treat our patients. I will show this study made in a public hospital in Brazil that compares the results in terms of costs where in patients underwent RFA and thyroidectomy. You can see that not only the length of hospital stay is much lesser for patients underwent radio frequency ablation, but especially the costs when you compare these both alternatives. Of course, once again, it's for selected patients. It's not for any patient with thyroid nodules. It's not any patient with thyroid cancer, but the secret of the success is the correct selection of the patient. It's very important to see the best treatment for the best patient. Thermal ablations is not for all patients with thyroid cancers. You have a specific setting of patients that are elective for this treatment. But when you have the correct selection, when you compare the costs and the results, RFA, it's a very good option for these patients. And these studies showing that RFA is cost effective when compared with conventional surgery. So who will pay for these treatments? Of course, it's a local question, but it's related to local investments policies in public health. It's related to regulation of health insurance companies. It's related to local legislation for the adoption of new technologies. And in few cases, the patient investment that decide to pay for it. But in Brazil, for instance, where we now have some insurance companies that start to pay for this, and for some public institutions, step by step are starting to consider these techniques, and some patients also wants to pay for this treatment. And how to prove the cost effectiveness of this? Once again, the correct patient selection for the best results. This very elegant paper from Zhang, it's a Chinese paper showing that when you treat micropapillary thyroid cancers, in terms of efficacy, is similar when you treat micropapillary thyroid cancer by surgery or by RFA. And when you compare the costs of the surgery with the the cost of surgery with minimally invasive treatments, the cost of RFA, specifically in this study, is lower, and also the complications are lower. So, for careful selection of patients with micropapillary thyroid cancers, the oncologic outcomes after 5 years are the same, and the complications and costs were lower, and the quality of the patients was better. And we know that longer follow-up and additional studies are needed, but this is a good example. I show another challenging case is another challenging case of a patient with micropapillary thyroid cancer, not elective for active surveillance, and the patient option was a minimally invasive treatment, RFA. So you can see here the tumor, a very small tumor, and 2 months after RFA, the treated area bigger, much bigger than the tumor. After 6 months, the nodules, the treated area started to shrink, and after 1 year, you can see a retraction on the area where was the tumor. So in this case, also it's not it's a little bit challenging, but you can see the efficacy of RFA for these tumors. Here, for neck metastasis, I will show another case that RFA could be a good option for selected patients once again. A patient underwent in 2014 a total thyroidectomy for a T1B papillary thyroid cancer. In 2017, a recurrence. It was underwent a central neck dissection plus iodine therapy. In the 2022, in the follow-up, the ultrasound follow-up showed 2 lymph nodes level 6. The final readout showed that was metastasis of papillary thyroid cancer. So you can see the lymph node, one with 1.1 cubic centimeters, and the same lymph node after 3 months of RFA, 0.3 cubic centimeters, volume reduction of 74%. And the lymph node 2, previous RFA, 0.3 cubic centimeters, and after 3 months, 0.07 cubic centimeters, 80% volume reduction. So when you compare the results, this systematic review for metastatic treatment of papillary cancer by RFA, you can see that not only the volume reduces, but the thyroglobulin, thyroglobulin, and the levels of recurrence are very, very low. So we can say that thermal ablations for micropapillary thyroid cancer and neck metastasis represents a new option for treatment of these tumors. This procedure is feasible and cost-effective for select patients and may represent a good option for treatment in under-resourced areas. This new modality represents an alternative to surgery in selected patients and should be performed by trained physicians. And of course, future research is needed with longer follow-up and more population studies. Thank you so much.
Thank you, Dr. Volpi. I think we'll move on to the next presentation and take all the questions together at the end. I'd like to call Dr. Kowalski to give his talk.
Yes. Can you see my screen?
Yes, we can.
Good. It's okay. Good. So I'd like to thank the American Heart and Neck Society for the invitation to be here today. We'll talk about developing survivorship and rehabilitation programs in under-resourced setting. I have nothing to disclose, and this is the layout of my presentation. When we analyze the incidence of head and neck cancer in several countries, we can see that in most of the areas where we are living in low resource settings in countries that are under development, we have a high incidence and also, and more important, a high mortality due to most types of head and neck cancer. So the reasons why we have these challenges in providing adequate care in head and neck cancer patients are usually said that the most reasons are limited access to diagnostic tools, the delays in diagnosis and treatment initiation, what is really very important, lack of specialized healthcare providers, inadequate infrastructure for treatment and follow-up, and also very important, the financial constraint affecting the availability of modern treatment modalities. In this study from the National Cancer Institute in Brazil, with almost 50,000 patients treated in the period of 2000-2017, we can see that in the country, about 80% of the cases of oral cancer that we have are diagnosed at stage 3 and 4. In these two studies that we have participated, one using data from different institutions in Brazil and the other countries in South America, it was sponsored by York. 77% of the patients had diagnosis of all head and neck cancers at stage 3 and 4. And in the right side, you can see a study that was particular to the population of patients treated at the AC Camargo Cancer Hospital, which is a private hospital, a cancer hospital. Situation was a little bit better, with about 60% of the patients diagnosed with disease at stage 3 and 4. But one of the main problems that we have is that we have the diagnosis, but the time to start the treatment is usually long. You can see that in the state of São Paulo, in the year 2000, the median time to start the treatment was of about 50 days. And the situation became worse in the year 2012, where the median time was of about 80 days. So the problem is that we have the number of cases are growing, are increasing, but the number of institutions to treat patients are the same for a long time. So these factors contributed to the disparities in patient outcomes and overall survival rates in under-resourced settings. And how to address these challenges? Well, we can implement standardized care protocols. We can utilize new technologies, and also we should develop survivorship and rehabilitation programs. With these three with these three things that we could do without using a large amount of money and without disturbing the current practice too much, we could improve the quality of care and the outcomes of head and neck cancer patients in this setting. So, what's the importance of developing standardized care protocols? First of all, it would help to ensure that patients with head and neck cancer could receive consistent and high-quality treatment regardless of the resources available. And second, by establishing clear guidelines and procedures, healthcare providers can offer standardized care that is evidence-based and effective. One of the problems with evidence-based medicine is, well, in some parts of the world, is that we are underrepresented in clinical trials. Most clinical trials are concentrated in developed countries. Less than 3% of the patients, even in developed countries, less than 3% of patients participate in clinical trials. Cancer patients in Latin America are clearly underrepresented, highlighting some of the difference between regions of the world in access to adequate cancer treatment. So less than 5% of the patients in Latin America in clinical trials come from Latin America. Well, when we have guidelines to treat patients, most guidelines are based in these clinical trials. And most people in our area use NCCN guidelines, but NCCN guidelines cannot be really applicable in all areas of the country, like Brazil or other countries, especially in Latin America. We try to use the core resources guideline from NCCN, but in several instances, in several places in Brazil and other parts of Latin America, Africa, and I would say also from Asia, only basic resources are available. And even these minimum resources are not always available in all areas. We recently reviewed all the published guidelines in oral cancers, for example, and we could establish the minimum requirements for diagnosis, staging, and treatment. And we also, using these guidelines, we could establish the suggested better way to manage oral cancer patients. In the more recent years, we are having more specific guidelines. For example, this guideline from India to treat oral cavity cancer is really very, very important document that shows how to deal with oral cancer patients in a developing country. Recently, we published our consensus on the treatment of different head and neck cancers in Latin America. It was there was a huge discussion between representatives from several local societies in the area, and they discussed our real problems to establish the standards of treatment. We were based it was based, of course, in the literature, but with a lot of local information that was reviewed by this group. So we can really, with standardized care, we can improve treatment efficacy because we help streamline treatment process, leading to better adherence to evidence-based practices. And we can also reduce disparities, helping to minimize disparities by providing all patients with equal access to evidence-based treatment protocols, regardless of their socioeconomic status. But the majority of patients presented, as I have shown, with advanced stage of the disease, and they have comorbidities, nutritional problems, depression, poor compliance, and in the real world, several cultural factors, economical factors, and social factors make it almost, I wouldn't say impossible, but it creates difficulties in using guidelines, the recommendation from guidelines, and in real practice, a lot of patients are treated according to the experience of the team that they are taking care of the patients. And so not always this real practice is based in evidence from the literature. Well, we can also discuss the problem of using of innovative technologies and especially advanced imaging techniques, precision medicine, telemedicine, robotic surgery. Uh, all these play a crucial role in hastening diagnosis, treatment, and follow-up care for head and neck cancer patients. And it offers opportunity for more accurate diagnosis by personalized treatment plans and improving monitoring of patient progress. I think that one of the most easy ways to show our progress in head and neck surgery, especially, is the success of reconstruction. These three patients had similar clinical situations treated in different times. One patient without reconstruction, other patient with reconstructed with myocutaneous flap and a plate, and this patient reconstructed with microvascular flap. Of course, with microvascular flap, it's a longer surgery, it costs more, but the results are fantastic. So there's no discussion that we should use this kind of technology to better treat our patients. But unfortunately, in real world, only in this review from it was a survey in different services in Brazil. Only 59% of the services with surgical oncology, they have microvascular reconstruction available. And also in these settings, only 71% of the service have speech pathologists to deal with the rehabilitation of the patient. So survivorship and rehabilitation programs in head and neck oncology in these under-resourced settings are crucial elements to aiming to enhance patient outcomes and overall quality of life. These survivorship programs encompass various essential components to cater to the needs of cancer survivors. Interventions, surveillance, and care coordination are the key. So the aims of the surveillance are cancer surveillance, it's the oncologic target of the program, surveillance for adverse effects and management of treatment-related effects, management other medical issues that are very frequent in these patients. Of course, rehabilitation is another very important issue, psychological support, and lifestyle counseling is also very important. The significance of survivorship and rehabilitation programs could be summarized as they are essential for addressing the long-term physical, emotional, and psychological needs of head and neck cancer patients. These programs aim to support patients in managing treatment side effects, improving quality of life, promoting health behavior, and facilitating their transition to post-treatment care. The challenges in developing programs in under-resourced settings are limited healthcare infrastructure, as I have mentioned before, lack of trained healthcare professionals. It's really very important, and we people that work in cancer centers or at universities, we have to prepare not only the physician but